I'm very happy to introduce our keynote today, Mike Hall. I don't normally read all the stuff that's in your book, but I'm going to do it for a moment. I hope Mike doesn't mind. But Mike is with the National Association of States United for Aging and Disabilities. Prior to that, he served as the first director of integrated health systems at CMS, and he's responsible for nationwide policy development, regulatory review and oversight, technical assistance, and program improvement in the areas of Medicaid managed care, managed long-term services, and supports integrated care, PACE, PCCM, health homes, and payment reimbursement innovations. Everything that we need to be talking about are the kinds of things that Mike's been involved in. He has served in other states, in state government. He's served 4 governors in 3 states, most recently as the Secretary of the Department of Aging and Long-Term Living in Pennsylvania. He's also been in Vermont and in Maine, and we're very, very glad that he's here today to give us our keynote presentation. Mike, come on up.
All right. Well, it's great to be here, and let me just say that one of the things that Marco and I talked about when we discussed the conference and the possibility of me speaking this morning was trying to get folks thinking. I think the word provocative was used, although I'll try and make sure that I can still find safe passage to the back of the room when I'm done. When I worked in state government and when I was at CMS, and actually at CMS is harder to do this than state government, I had an approach to public speaking which I described as walking the fine line between being candid and being fired. And it's partly because I think we don't often talk about, there's a book in leadership that I've used that contains the idea that in too many workplaces there are the things that are called the unmentionables, which are the things that everybody knows but nobody wants to talk about in public. And they are corrosive and damaging overall to the organization. And the same thing happens in the policy work that we do. There are so many things that we're afraid to touch and afraid to talk about, and yet the longer that we don't talk about them and confront them, the more that they undermine our ability to see what's really happening, the ability to see our mission to the people that we serve, the effect that we have on those people, and ultimately the credibility that we have in the eyes of society, in the eyes of the consumer and the people we serve, and in the eyes of the legislature. So what I have put together here is a sort of a national perspective based on the work that I've been doing for the last several years that talks about managed long-term services and supports, what its sort of sweep is, how quickly it's coming and where it is, but also some of the reasons that it has gained so much momentum so quickly. I'm going to try and move through that section pretty quickly and be informed. This is not going to be the ABCs of managed care. What it is just trying to give you a sense of what's happening in the states, and then I'm going to try and move as quickly as I possibly can into some of the later slides that talk about what does that mean for us? What does it mean for the system? What does it mean for providers? How do you think about where you go from here? What's the new reality going to look like? And hopefully with that, I'll have some time at the end for some questions, and we can go from there. So, and also, disclaimer, the things that I'm going to say are not New York specific. I purposely tried to pull the zoom lens back a little bit, and they're not intended to be a critique or a commentary on specific initiatives or the status quo here in New York. But I think that as I talk about these programs, and the perspective I'm going to bring to this are home and community-based programs in a larger sense. It includes programs that serve seniors, and the aged, folks with physical disabilities, and folks with developmental disabilities as well. And I'm guessing that at least some of the things that I'm going to say at some point are going to resonate with you, and I'm going to see some heads nodding. And others of you may have really strong disagreement, and you can have at me when I get to the end. I don't wear my bulletproof vest to these things. So here we go. What do we see happening? Well, first of all, what you've already probably observed, dramatic, very rapid shift away from fee-for-service and towards managed care and other bundled payment or outcome delivery models. In 2010, 72% of the people in Medicaid nationwide were already in managed care. But those 72%, so 3 out of every 4 were already receiving their Medicaid services in a managed care environment, but only 30% of the spending was attributable to those folks. Why is that? Because most of the folks who were in prior to 2010 were folks who were connected with the TANF or CHIP programs. They were younger families, they were adults and children, and in reality, they were not very expensive. They're relatively healthy, their cost of care was pretty low. The expensive folks in Medicaid, elderly, developmental disabilities, physical disabilities, in most states, with just a handful really, with the exception, were carved out and remained in fee-for-service 1915C waivers. In 2011 and 2012, that started to shift, and it started to shift very quickly. In several states, Kentucky, Louisiana, New Hampshire are just a few examples where they had 0 managed care. Not a single person, no MCOs within their state boundaries. They indicated and they went to CMS and said, we now want to go to managed care, what I call wall to wall, border to border, every population, comprehensive managed care. In other states where managed care already existed, either in that younger population or in some cases where they had brought it to some of their HCBS populations as well, but it tended to be concentrated in certain parts of a state. In Texas, for instance, in the big cities, they announced that they intended to expand their managed care footprint to cover all of their beneficiaries. And what that meant, in the space of just a few months, we had a growth in managed long-term services and supports in this country that was several million people. When Texas did their expansion, 2 million people came in just in Texas alone. You now have a situation where, with the exception of Pennsylvania, which started to move in this direction and then stopped, and who knows what they're doing right now, even though I live there, but eventually they will be there as well. 5 of the 6 largest states in the country, which represents a huge piece of the pie in terms of the people who receive Medicaid, are in wall-to-wall managed care or in the process of implementing right now. Within 2 years, we do not expect to have any significant fee-for-service presence in our Medicaid program. It's a quote from a Medicaid director of one of those large states. But think about that for a moment. In 2 years, we do not expect to have any significant fee-for-service presence in our Medicaid program. What else is happening? Most of the states are also proposing at the same time to migrate most or all of their carved-out populations into managed care. And it wouldn't be surprising, frankly. Remember those numbers we started with, 72% were already in managed care, 30% of the spending. I expect by 2015 we're going to be at a place where more than 90% of the Medicaid recipients nationwide are in managed care, and 50 to 60% or more of the spending is going to be in a managed care environment. Why is that? Well, it's where the money is. Here's actually a budget chart that I used when I was secretary in Pennsylvania a few years ago. This is the kind of thing you take the legislature at the beginning of the legislative session to justify your appropriations. On the left side, you have Medicaid enrollment. On the right side, you have Medicaid costs. But look at what it says on the bottom, because I've done the math for you. Elderly and disabled, including developmental disabilities and physical disabilities, 34% of the Medicaid lives, 34% of the beneficiaries are in those populations. 68%, almost 70% of the spending is attributable to those populations, which means if you're a Medicaid director, as I have been in 2 states and actually ran the long-term care program in Pennsylvania, that's where your problems are every single year. So Just a couple of quick maps, and I think actually these are out of date, but they refer to what I was talking about before. They're out of date in the sense that more states should probably be colored in. Of the 16 states that already had managed long-term services and supports, 9 announced as of last year that they intended to expand. Those are the red states. And then 11 additional states that did not have any folks in managed long-term services and supports. Those are the green ones added on here. So we're at a point now where we are between 35 and 40 of the states either have implemented or will be implementing managed long-term services and supports. And we're also at a place where, in terms of the developmental disabilities population, you're looking at somewhere between 15 to 20 of the states so far have already migrated those populations into managed care or have indicated to CMS that they're on a pathway to do that. Why so fast? Well, again, it comes back to money. This started happening in 2011. What happened just before 2011? 2010, which was an election year. It was also the absolute depth of the recession. And states were getting killed in terms of their state deficits. The deficits, as calculated by the National Association of State Budget Officers through 2013, showed that on top of the $230 billion, $250 billion that states had accumulated in through 2009 and 2011, there was another $175 billion on top of that. So if you add that up, you're talking about, if you go state to state, New York, New Hampshire, North Carolina, and you add up what they were running in terms of state budget deficits from 2009 through 2013, $500 billion. And you felt it here. It was being felt all over the country. It created enormous pressure, particularly on a bunch of new governors. And that's not an insignificant fact. The other thing that happened in 2010, 29 new governors, largest freshman class in history. And I guarantee you, having gone through this several times, that as soon as they were elected, probably the day after Election Day, they sat down with their transition team. They looked at the transition reports that were written by the outgoing secretaries and commissioners with basically a very candid description of what the problems are and recommendations going forward. And on November 5th, they started trying to figure out what the heck are we going to do? Because virtually every single one of them, both Republican and Democrats, inherited a nightmare. And at the top of that list, developed both by the outgoing folks and by the new budget officers and the new senior advisors of those administrations, we have to do something about the fact that we have 70% of our spending in those carved out populations in Medicaid, and our trend is out of control. Our per member per month cost, the PMPM, is higher than anything else that we're doing. Let's look at the next bullet there. Total Medicaid spending increased by almost 8% in FY10 and 11.2% in FY11. Way, way, way faster and higher than the average, than the spending trend for healthcare overall. The long-term care spending trends are completely unsustainable, even if you don't factor in the baby boom demographic. And then what happens? The ACA passes, and you cannot read the ACA. You cannot read the health care reform bill without picking up the message. The message is fee-for-service has failed. We have done a poor job of managing chronic disease. We have to figure out how we integrate our long-term care and our primary care and our mental health and our substance abuse systems, and we have to put together a payment system that starts to get its arms around chronic disease. At the same time, in that same bill, you have the duals alignment, the duals offices created, and financial alignment, which is intended to not only bring together the services for all those populations, but also to bring together their payment, because in reality, Medicare and Medicaid play terribly together and work at cross purposes. And if that wasn't enough, and if you're a Medicaid director, you're looking at Medicaid expansion and 17 million new beneficiaries coming into your system, and if you're and let's talk about who those folks are. They tend to be younger, but they tend to be folks who have been out of the healthcare system. They have a lot of pent-up demand and untreated needs, a very high incidence of substance abuse, very high incidence of behavioral health disorders, and you're a Medicaid director, and you already got, I sat in a meeting with state leaders back in 2010, and we went around the room around budget time, and we were asked what was the budget that we were facing. Even Delaware had the word billion in their narrative. So if you already have a 4 or a 6 or a 60 or $120 billion problem, and you're looking at the prospect of 17 million new beneficiaries coming into this program in fee-for-service and unmanaged care, you are scared to death. So, you have at the same time, as I was talking about before in those discussions during the transition period, the reality that every state Medicaid agency, if they do that calculation that I showed you before of where their beneficiaries are and where their costs are, basically come up with the same pie chart that every legislature sees every year, which is the 80-20 rule. 20% of your beneficiaries are spending 80% of your dollars. And you have really the fiscal implications of not dealing with that. You have an environment, I think, frankly, that falls into the maxim, never let a good crisis go to waste, and if not now, when? And what I would say is for those who believe that the only reason that the Medicaid program nationwide and that states have moved down this path is because of the fiscal problems and the deficit, I would say it's not the only reason. It is certainly the catalyst. It certainly was provided the energy for doing it, but it did something else, and politically, particularly if you're in state government and you deal with legislatures and you have to sit in front of appropriations where you have all kinds of stakeholders who have agendas, many of whom are interested in preserving their revenue streams and preserving the status quo. When I say never let a good crisis go to waste, reform happens in the midst of crisis. In fact, it almost always happens. It only happens in the midst of crisis. And what happened in 2010 and 2011 and 2012 is it became, this goes back to what I said at the beginning, the unmentionables. It became possible to talk about the stuff and to propose initiatives and to drive forward initiatives and get the votes for them in the legislature that you would never get if the economy was healthy. That would not be possible to talk about in public if things were going well. So, the shift is toward various types of coordinated care. Some of them were mentioned in the little bio that Marco talked about: primary care case management, health homes, accountable care organizations, parentheses, whatever those are, close parentheses, and other bundled payment strategies. But the bigger message is integrated coordinated care, and most of it is in the form of managed care. It's a recognition that we have done, and I'm not going to mince words. This isn't provocative, this is just true. We have done a poor job of addressing chronic disease in the Medicaid program and in the Medicare program. We've done a crummy job, and an even poorer job of integrating physical and acute care. How many of you have heard or read, if you read, then you get gold star, the Institute of Medicine's report, Crossing the Quality Chasm? Okay, 3. You might want to think about looking at it. Came out in 2001, so what is that, 12 years ago. 12 years ago, the Institute on Medicine predicted that we would be where we are today. And why? Because they said in 2001 that the system was terminally broken, and the largest reason for that was that we were not integrating primary care with we were not dealing with co-occurring disorders, we were not dealing with the interface between primary care and long-term care, because even our substance abuse and mental health systems in many states can't get along with each other, so they operate in isolation. So we now have, in reality, in most states, what we have built over the years are Medicaid-funded long-term care delivery systems where the 1915C waivers are almost completely estranged from the physical and acute delivery system. Why? Well, federal and state funding historically have emphasized, they have measured, they have paid, there's a reason I underline those words, for things like deinstitutionalization, for rebalancing, which is to get people out of institutions into the community, on independent living, Olmstead compliance, in some cases participant-directed care, but they have not emphasized health status or outcomes. You will be hard-pressed to find a state, other than those that were the pioneers in managed long-term care, that ever, in their budget addresses, in their conversations with the legislature, in their internal strategization, in their conversations with communities, talked about the fact that we need to get better outcomes. Why? Because they haven't even been measuring outcomes. Because in the home and community-based services system in this country, I'll step back for a moment. Right now, as managed long-term care is taking hold, there is a lot of concern, as there ought to be, that we don't have good ways of measuring the performance of managed care organizations as we go into this world. I'll talk about this in a few minutes, but I'll probably skip over it because I'm talking about it now. We have good ways of measuring clinical outcomes. We already have a pretty good sense of what those metrics will be. We can drive reimbursement off of that, but we don't have a particularly good way of measuring what is the non-clinical aspect of the work that they're going to do? How do we focus on the home and community-based services aspect? How do we make sure that they're committed to independent living, to keeping people integrated in their communities, that they are continuing to pursue rebalancing? There certainly are things that are built into managed care inherently in the reimbursement dynamic that will help you get to places you need to go. If you want to keep people out of nursing homes, managed care is a great way to go, because when a nursing home costs $80,000 a year and you have to pay for it under your capitation, nursing homes are not managed care organizations are not interested in having the people who they are responsible for wind up there because they get killed. So they do somersaults to try and figure out how do we keep people in the community. But how do we make sure that they focus on the other aspects of what we have been trying to do for the last 30 years in terms of integrating people into the fabric of community? But, and here's why I was so, shall we say, passionate a few moments ago. Before we spend too much time criticizing and wringing our hands about the fact that managed states have not yet figured out with great certainty how they will measure those things, let's be honest with ourselves. Those measures did not exist in fee-for-service. We did not ask providers to report to us on how we were getting quality, how we were measuring experience of care, what quality of life looked at. What we have done, and in fact, if you look at the quality framework that CMS has mandated that states use in their home and community-based waivers, what is it about? What does it measure? Answer: widgets, units, volume. How many people did you serve? How many times did you see them? How many services did you render? It doesn't talk about what's the quality of care that you've delivered to them. Are they satisfied with the services? And importantly, more than anything else, you will find nowhere in those measures or in measures that states have been using, nowhere are they getting better. Are we helping to integrate them? Are we changing the trajectory of their lives? Are they improving? Are we able to move them off of services? It's not in there. And if it's not in there, people don't do it. So, my next slide, paying for outcomes instead of volume, which is where we're headed. The shift is driven, at least in part, that we don't keep people healthy, that we have not, in fact, fulfilled the promise of rebalancing. In a lot of states, and AARP and NASUIT are about to come out with a report on this. If you look at what has happened in terms of state investment in home and community-based services, it has plateaued. Partly it has plateaued as a result of the recession. Partly it has plateaued because even coming out of the recession, states are challenged to put resources into, to have the resources to put into home and community-based services after they get done dealing with the things that are mandated by Medicaid. Mandatory services, and in many states, institutional care, including nursing facility care, is a mandatory service. So you pay for that first, and if you have anything left over, literally, and if you have anything left over, you put it in home and community-based services. So today, 25 years after the drive towards rebalancing our systems began, we still have most states that are looking at 60 to 65% of their populations in institutional settings. We still have states, if you look at the annual report that Truven, formerly Thomson Reuters, does, that are at something like 80% or 85% institutional care. We have not sustained the expansion of independent living, and disturbingly, in many cases, across many programs in many of our states, our programs, if we were honest with ourselves, are not person-centered. They have been built around the idea that we provide settings that are easy to operate, that we have programs that are friendly to providers, but they don't, in fact, structurally or operationally focus on whether or not this is, in fact, what the person would want. Is this the kind of life they would want to have? Are these the choices they would make? In fact, in far too many cases, and I'll talk about that in a moment as well, we have systems and providers that go out of their way to avoid having those conversations with folks, because it would mean that they had to do things differently than the way that they do them today. Now, my next bullet, this is one that I put in every single presentation that I do, because when folks say that they are in favor of people living independently, with dignity, integrated in their communities, but then they say, but we're opposed to managed care, or we're opposed to the drive that we're seeing towards integrating our systems, I say it is extremely difficult, nearly impossible, to be integrated in community, to live with independence and dignity if you're not healthy. It has been convenient in this country not to talk about the reality that if you are suffering from chronic disease, if you have had a limb amputated as a result of untreated diabetes, if you suffer from congestive heart failure, if you are debilitated from a stroke as a result of untreated high blood pressure, you are not integrated in your community. You may still be in a home-based setting. You may be in a group home, but the chances that you are engaging in the community, that you are getting out of your home, that you are able to participate in society, pretty darn low. Living alone and isolated on a couch or in front of a TV is not, I think, what we originally had in mind. I started working on the home and community-based services movement in the early 1980s. And today, in too many of our programs, in too many of our states, we take credit for people not being in institutions and being in home and community-based settings, either in their homes or in what we characterize as community-based congregate settings. But the reality is that many of those congregate settings are just smaller institutions in disguise, which is why the Department of Justice is suing everything they look at when they look at where states are with these programs today. And the reality is that we take credit for lots and lots and lots of people, millions of people in this country, who sit alone every single day in their homes, do not go out, do not have visitors, do not have anything that vaguely resembles community participation or integration. And I ask you, really, is that independent? Really, is that dignified? Is that what we meant by integration? So, as I said before, we need to move to a place where reimbursement supports, where reimbursement incentivizes, where reimbursement is aligned with the idea that we have to get better outcomes, that we have to focus on improving the quality of the care that we focus on. And quality of care here, as I said before, is not simply a question of clinical, although that is terribly important, as I said above, but also what is the experience of care? How does it feel to be on the receiving end of the services? How does it feel to be the end user? And how are we doing in terms of the quality of life that people experience? And I'll come back to it again, though it's not on the slide. Do we change people's lives? For years and years, when I was running organizations and we would talk about what is the catchphrase that we want to have that gets people up in the morning and gets them excited about coming to work, because I personally care deeply about public service and about the work that we do. In this world, I think it's the work of the angels, and I want people who work in my organizations to feel as though they are serving a noble purpose. What's the noble purpose? And for me, it has been, and I've said it to every place I've worked, we change people's lives, or at least we ought to. We ought to change them for the better. We ought to leave them at the end of our work better off than we found them. We ought to change the trajectory of their lives, and we're not doing that today, and we must. So, what does it all mean for HCBS? Well, as if you didn't already know, the world is drastically changing. The HCBS system that we spent the last 2+ decades building was, in economic terms, vertically integrated. How many of you remember Economics 102 from college? Vertically integrated means you control everything from the inputs to the outputs. In the HCBS systems in most states, the HCBS providers, whether they were area agencies on aging or centers for independent living or disability agencies, served as the gateway. They did the front-end functional need assessments. Then they did information and referral. They told people what their options were. Then they developed the case or service plan based upon the functional need assessment. Then in most cases, they served as the case manager or service coordinator. And then in very many cases, in many states, they also served as a service provider. From the moment you walked in the door till the services you got, you didn't see anybody or talk to anybody other than that agency. Depending on the delivery system, they were sole source geographic monopolies, and they had virtually guaranteed revenue streams year in and year out. And, frankly, they have been riddled with conflict of interest. They have had, because of their vertical integration, the ability to drive business to their own doors, to write their own tickets. Their ability to do the functional needs assessments allows them to decide how many services does this individual need. And then their ability to write the service plans to match that, and then to bill for the same services that they're delivering, means that they had ability to basically write the check and hand it to the customer and say, here's how much you have to pay. The ability in a vertical integration system is also one that allows you to act to the detriment of competitors, to keep other potential providers out of the market, to discourage consumers from using them, or in most cases, to not even tell consumers that there are other options available. We live in a world where the vast majority of home and community-based services are rendered by either nonprofits or by governmental agencies, in a lot of states, county government. And yet, the reality is that even though they may be 501c3 and they may be part of government, they are business. And they have become really, really big business. If you go into a lot of parts of this country, if you go into Pennsylvania where I worked, our area agency on agings and our centers for independent living, particularly in the cities, they were multi-million-dollar corporations. And the fact that they file a 501c3 with the IRS every year, if you don't think that they were constantly focused on how do we get bigger, how do we preserve our revenue streams, how do we get more market share, you are mistaken, because that was foremost in their mind on a day-to-day basis. So, what does MLTSS do? Well, it disrupts that market almost completely. When you hear the phrase disruptive innovation or disruptive technology, do you know what I mean by that? It particularly has emerged in the last few years as in the high-tech world, but it's the basic idea in economics that you have a mature system and it hasn't changed much, but it's sort of rolling along, and then something comes along that undermines all of the basic assumptions, and within a very short period of time, the mature system finds itself out of step and fairly shortly extinct, because the new innovation, the new system has displaced it. So in contrast to the sole source geographic monopolies and the vertical integration, what we're looking at in home and community-based services as managed care comes on the scene are the following realities. It's not clear that home and community-based providers, even if they were doing it in the past, will be doing the assessment, the level of care of function going forward. It varies from state to state. The best case is that they will do it and that states will require them to use a standardized assessment tool, but that there will be an independent assessment entity. If the provider are allowed and selected to do that, they will be required to be independent, which is not a small issue, because it means you can't be vertically integrated. You can't do the front-end need assessment and then also have a book of business down the hallway where you're the provider that's going to be using those, the service provider that's going to be delivering those services. In essence, you have to choose what line of business you want to be in. You want to be assessment? Fine, you're assessment. You want to be a service provider? Fine, you can be a service provider. Can't be both. That is where the world is going. Providers may seek to compete for them, but they'll be required to be conflict-free. What is almost universal is that home and community-based systems and providers are not going to be in the care and service plan development business anymore. Managed care organizations are going to be doing that because it's part of developing their package of services in order to meet the person's needs and to stay within the capitation. In most cases, it'll reside with the MCOs. There are a few isolated cases. Massachusetts is one, Ohio is another one, where in the aging services system, the states have required MCOs to contract with area agencies on aging to do the care and service plan function. Do not look for that to be a trend. It is not going to propagate across the country. And obviously, if you take assessment off the table, if you take care plan development off the table, and if you take the actual care management off the table, you're looking at a huge economic impact, because for many providers that were billing to Medicaid, and particularly in service systems where Medicaid was the game, where there was no significant Medicare presence, where state dollars were not a big part of the budget, you take those three elements out of the budget, and you're looking at most of the revenue that they were previously earning. So what are the opportunities? Well, one of them is that states have spent more than 2 decades building the current delivery systems. They have spent more than 2 decades investing in expertise, in funding agencies that have learned how to serve these populations, and I would argue that most of them are not especially thrilled about the prospect of starting that all over and building a new parallel delivery system that they fund the MCOs to develop. At the same time, most MCOs are not going to be interested in replicating those services and having to build their own capacity internally unless they have to. And if they can buy those services from existing providers in the market, off the shelf, they will do so because it's economically efficient to do that. And in an environment where MCOs are concerned about whether or not they have the capacity, whether or not they have the competency and the literacy to serve these populations, they can fast-track that by working with the players in the existing provider network. Let's talk about that capacity and competency for a moment. I hear a lot of people, in fact, I was up in Boston a few days ago, and this was something you heard a lot during the open discussion, concerns that managed care organizations are coming into the market and they don't know anything about these populations. Let me suggest that you should not be too quick to go to that conclusion. First off, in most of the states that have been moving in this direction and have issued their procurements, their RFPs to move to manage long-term care, in almost every one of those markets, you have 3 big companies that have been bidding on them that are very experienced players in this market, and some of them have been in it for a decade or 2 decades in what I refer to as the pioneer states. States like Massachusetts, like Arizona, like parts of California, like Minnesota. Those companies are United, Amerigroup, Centene, and they will be in almost every market. That doesn't mean that they know New York or that they know Pennsylvania, but they know the business and they know the populations and they know how to scale and they know how to hire people from the existing delivery system to come work for them. At the same time, and this is scarier, you do have, depending on the state, other players that do not have track records here. You have managed care organizations that have been very active in Medicaid in that under 60 market serving kids and families, and now they want to move into managed long-term care, and what they know is primary care with kids and families, but they don't know seniors, they don't know TBI, they don't know DD, they don't know mental health, and so they do have a learning curve. And then, worst case scenario, and all you have to do is look at the procurement they were doing down in Florida, you have some companies bidding on those contracts who have never done managed care at all. They have not been managed care organizations, and personally, that scares me to death. But it's going to be a mixture of those things. And if states do the contracts right, they will create very strong incentives for plans, whatever thread they come from, to come up to speed and get over that learning curve. What are the challenges for providers? Not all providers will or should survive. There will be, depending on the delivery system, an unprecedented number of agency failures, closures, mergers, consolidations, smaller providers being absorbed into bigger ones, or a bunch of small ones getting together to create create regional coverage. In many states and many of our delivery systems, and this includes some of our DD systems across the country, there are too many providers. And so several states are actively moving to combine service regions and reduce the number of agencies. MCOs, from a business perspective, are not interested in contracting with a multiplicity of providers. There's a principle here called one throat to choke. You know what I mean by that? If you're a managed care organization and you have vendors working for you, subcontracting, serving as providers, doing some of these functions, okay. New York is notorious for having a lot. Pennsylvania has a lot. Just speaking of the aging systems, and I won't even talk about our disability providers or our financial management services, we had 52 area agencies on aging in Pennsylvania. Many of them small agencies in rural areas on the New York border. I'm just telling you, managed care organizations are not interested in contracting with 52 providers. They want to have 1 or 3 or 5, not 52, which means either those 52 are going to have to figure out how they form some sort of collaborative so that when something goes wrong, when an agency is doing a poor job and the managed care organization is, pardon my language, pissed off because the numbers are going in the wrong direction, there is one throat to choke, not 52. There's not going to be a blind man's bluff search for accountability. In this world, volume and economies of scale will matter. The loss of sole source streams and the shift will, this is practically Darwinian, is going to separate the weak from the strong and the high performers from the poor performers. And I ask you in the last bullet something which is terribly important, and I'm going to add something that's not on the sheet. Should states require MCOs to contract with poor performing agencies? And I would argue no, even though that's where a lot of the advocacy is out in the states. And if you want to know why, aside from the fact that it does violence to the idea of trying to improve outcomes, that it makes it very difficult for managed care organizations to stay within the capitation, it also is fundamentally wrong for the people that we serve. It is just wrong. Every person who has sat in the chairs that I have sat in has charts, has reports that you get practically every month that show you county by county, provider by provider, region by region, where your numbers are, what kinds of stats you're getting back, who the good performers are, who the poor performers are, You know where the problems are. And what you also know is that the folks who are served, who lived in the regions with the poor performers, do not get the opportunities to live with independence and dignity, do not get the opportunities to have quality of life that people who live in the high-performing regions do. In Pennsylvania, in the aging services system, you have some counties that are fully balanced, 50-50. And you have a county that is right south of where I live that still has 85% of its people in nursing homes. And I say to you, it is not right, and you cannot look the citizens of that county in the eyes and say, if you are unfortunate enough by the accident of geography to live in that county, you are sentenced to being in a nursing home with an 85% certainty. But if you lived across the border, that would be a different story. And those are exactly the kinds of unmentionables that we have tolerated for too long, and that in fairness to the people who we serve, we have to fix. So what does the new world look like? Providers are going to have to fundamentally reassess their business models, and taking a cue from Marco's introductory comments, I assume that that's a conversation that has been going on here in New York for some time. But it means they're going to have to take a hard look at how they're staffed, where their costs are, because a lot of that infrastructure, how many people you hired, who you hired, what you have them doing, what you bought for technology, in many cases, whether or not you bought your own building, was all premised on the fee-for-service revenue stream. When the fee-for-service revenue stream is disrupted, that doesn't work anymore. So you got to go back to all your cost centers, and you have to evaluate, do we have the right number of people? Can we afford this building? What are these folks going to be doing? Do we need different kinds of folks? Providers will have to rapidly adjust to a market-based frame of reference, and they will not get selected just because they exist. The sense that the money was going to come in every year simply because you were an agency is not the world that we are headed into now. Providers are going to have to compete either in straight procurements or with other providers to get a share of the MLTSS business. And the goal, and this will be a challenge, and this goes back to my slide before about poor performing providers, the challenge will be a high quality, high value preferred vendor. The message that you want to have when you're working with an MCO is you want to select me because I'm going to do a better job. I'm going to help you get better outcomes. I can demonstrate that. Here's my track record. I will help you stay under your capitation. I will help you keep people healthier. If you can't say that and put your money where your mouth is, you are not going to survive in this market. The products and services, in short, must be market grade. And this, in boldface, is a practically revolutionary statement. Because in most of our delivery systems, you cannot say that they are market grade. In most of our delivery systems, if people were out in the private market, they would not buy what we're selling. So we're going to have to be prepared to offer a product that would be competitive and will be desirable and will be preferred. We need to understand this, that if you're going to be in this market, you have to align with the MCO's interests, which is if you can't improve their outcomes and assist them in staying under the capitation, you're simply not a viable player. And if they contract with you once and you don't do it, they're not contracting with you again. Providers are going to have to be conflict-free. This is coming, and the states are going to require it, and MCOs are not going to tolerate working with agencies that have the capacity either to do things to the detriment of the MCO or to line their own pockets and move business to their own lines. And I want to emphasize absolutely essential to accurately and competitively price services. It goes back to the first bullet, but it's about rates. In our systems, there is no science to the rates we've developed. How have the rates that we've developed in our DD systems, in our independent living systems, in our aging systems been developed over the years? I will tell you, because I've been there, and I actually am a specialist in rates. They are things like, well, we picked a rate 13 years ago and we've been inflating it every year. No kidding, most of the time. Or the legislature gave us a certain amount of money and we reverse engineered the rates to meet the amount the legislature gave us. Or we did a cost analysis in 1996 and we've been building off of that ever since. The rates that we have no relationship to the market, but more importantly, they have very little relationship to what many agencies' real costs are. And in this world, they have to. You know, I used a metaphor the other day that our rate structures in most of our systems are like things floating free of gravity, untethered to the world. And yet, if you're going to compete in this market, there are two things you have to know. First off, you are going to have to bring in a rate when you're talking to an MCO that is attractive enough to them that they're going to see the value proposition and they will buy the services from you. So it has to be low enough to get the business, but it cannot be so low that you go broke. And so you have to know where the sweet spot is. And if you pick it wrong, you're in deep trouble. So, what does it mean going forward as I round the curve and head for the finish line? There's a concern that the MCOs will have expertise in physical care, but not in LTSS, especially in the DD world. Will they demonstrate literacy and competency in serving those special populations? Will we require them to actually enhance and strengthen the principles of independent living, consumer control, person-driven decision-making? Will they advance the cause of rebalancing? All these things are what we ought to be focused on. We ought to structure our relationship with the MCOs, making it clear that those are the things we want to buy. MCOs do not get to come to us and say, this is how we do the business. I have actually had conversations with MCOs who want to compete in the managed care market when I was in Pennsylvania, and I would say to them, I need for you to do it this way. I need for you to offer a component that's focused on participant direction. And, admittedly, this was a few years ago, they said, well, we don't do that. And the conversation I have with states almost every week is, they don't get to say that. If you're a state, you're the folks with the checkbook. You get to decide what it is you want to buy. You get to say to managed care organizations, here's what we want to buy, here's what we're willing to pay for. If you're willing to give it to us the way we want it, we'll contract with you. And if you're not, well, thanks, we'll find somebody else who will do it. And it turns out MCOs, when you put it that way, are remarkably responsive to that line of thinking. But let's be clear. They are just as susceptible to the flaws, to the conflicts of interest, as the fee-for-service system is. And if you are not thoughtful about how you structure this, you will find yourself in trouble. How many of you saw this story? New York Times 2 weeks ago. What's the problem here? Well, the fundamental problem, when you boil the whole story down, is you move to managed care, managed long-term services and supports. You disrupt the current dynamic. You give care planning and you give service coordination to the managed care organizations. Okay, so far, sounds reasonable. What else did they do? They gave them assessment. And when you have assessment, you have the ability to control the front door. And somebody at the adult day programs figured out that it was going to be in the managed care organization's interest to get more and more people on their caseload and build utilization, so they started referring and recruiting people who, in reality, were not eligible for adult day services, sending them to the managed care organization and saying, we have a new customer for you. And the managed care organizations were apparently perfectly happy to take those new customers because they get to draw capitation on every one of them. Now, I shall say that this exact same scam was being operated in the fee-for-service market in Philadelphia a few years ago. So what does it teach you? It teaches you that managed care is not a cure for all evils. If you create conflict of interest, or if you allow for conflict of interest in capitation, it will happen just like it does in fee-for-service. So, I'm just going to say this at the end. We have to pay attention from the get-go on how we start this new dynamic. We have to, in the RFP, in the contract requirements, in the monitoring and oversight, and in reimbursement, you have to focus on what it is you want to buy and making sure that MCOs are paying really close attention to that. You have to be clear that you are going to measure their performance and pay them based upon whether they attain your objectives. Never forget these three maxims. People and organizations do exactly what you pay them to do. And as we know from the past 25 years, if you pay for volume, you get volume. If you don't pay them to do it, they won't do it. And the reason that we have some of the ills in the system that I described earlier in my talk is because paying attention to outcomes was not actually part of the reimbursement. There's nothing that said if you get good outcomes, we'll pay you more. So if you aren't getting paid, you don't do it. And finally, you get the behavior that you measure. States need to be serious about appropriate staffing and oversight. I am worried that as states have moved in this direction, too many of them have seen it as an opportunity to do staff reductions and budget savings. In the early days, unfortunately, you don't hear that as much now. Folks thought they were going to hand over their programs to managed care organizations and they would be able to have less staff because, in Pennsylvania, I had an entire floor of functions that I probably don't need anymore. I don't need to do provider enrollment. I don't need to do some of the provider audits I was doing before. But I need to do things I was never doing before. And if you look at the states that do this well and have been doing it for some time, Tennessee is a great example. You need at least as many staff as you had before, but doing different things. If you're a smart state, you're driving reimbursement off of whether or not they hit their performance metrics, which means, people know what I mean when I say the word holdbacks. When you structure a managed care contract based on holdbacks, you pay them about 90%, for instance, 90, 95%, 85%, pick a number, of what your contract says you'll pay them every month, and you withhold the remaining percentage. They have to earn the remaining percentage. And every single month, you decide whether or not they've earned it. How do you measure it? By whether or not they've hit their performance metrics. If they don't hit the performance metrics, they don't earn their money, they get paid less that month. Very powerful incentive. Turns out they pay a lot of attention to that. Tennessee has been very effective with that, and they put penalties on top of that. If you drop below your metrics by a certain amount, you get fined. They recently assessed a $13 million fine in Tennessee, and if that didn't wind up in the boardroom of the board of directors of that national managed care organization, I'm telling you, nothing does. But who measures the measures? Who looks at the reports? You can't do withholds unless you have the staff to understand, interpret, and then make recommendations on whether or not you're paying the full amount this month. So you cannot, this is a terrible, terrible place to take savings. So bottom line, biggest shift in our world since the 1915 Cs and Katie Beckett came on the scene. It is a watershed moment in the delivery system. It has lots of risks. We, by and large, in a lot of states, do not know what we're doing here, and we're figuring it out as we go along. And so we're going to have to be careful and thoughtful, and we're going to have to be prepared to make amendments and fixes on the fly. Even in Tennessee, they amend their contracts with their MCOs almost every month because they realized that the contract language they had in some respect was too weak, because they realized the MCOs have figured out a way to game it. Whatever it is, about every month they send out a letter to the MCOs attached to, say, Contract Amendment 49. Because that's the kind of proactive approach you have to take to get it right and evolve this to where it needs to be. We have to move to a system that is truly, relentlessly person-driven. We have to move to a place that meets this rhetoric of independence, integration, and dignity. That quote there, attain and maintain highest practicable physical, mental, and psychosocial well-being, ironically, comes from OBRA 87, the Nursing Home Reform Act, from more than 25 years ago. Attain and maintain the highest practicable level of social and psychosocial and physical well-being. They all come together. We have the opportunity to move the system to a new place and to get the kinds of outcomes that allow people to be healthier and integrated into the fabric of our community going forward, and to address a lot of the problems that have been dragging us down for the last few years if we pay attention to getting it right. So with that, let me wrap up and thank you for your time this morning.